Mr. Chairman. Senator Van Hollen.
Thank you, Mr. Chairman, and thank all of you for being here. Dr. Daphne, I'm going to start by asking you a question related to the collection of data. For many years, my state of Maryland has run an innovative payment model that started with regulating hospital pricing in the 1970s and now includes all-payer global budgets for hospitals in the state, with incentives to reduce total cost of care and improve efficiency and quality of care. So far, the model has been meeting the Medicare savings goals and improving care. As part of this work and its ongoing work on pricing, rate setting, and global budgeting, Maryland's all-payer claims database has strong hospital-based data. However, as you noted in your testimony, many states struggle to obtain data on ERISA plans because these plans are regulated by federal statute, and the Supreme Court barred states from requiring self-insured plans to submit data to address state databases, making obtaining plan data more challenging. How does greater access to claims data help regulators and policymakers address costs and health equity issues? And will the HHS pricing transparency rules for insurers help fill the gaps in price information that many states experience, or are additional steps necessary to make sure that they have the information that meets their needs?
Thank you, Senator Van Hollen, for the question. And also thank you to the state of Maryland for running some very impactful experiments for us researchers to study and to act as a laboratory for other states.
Got a Medicare question too.
You asked me how does it help for us to have access to a national all-payer claims database. It helps enormously because we cannot study the effects of mergers and acquisitions without health insurance claims. Right now we rely on the largesse and interest of commercial insurance companies. That interest has been waning. And in order for us to assess the implications of a range of phenomena, including private equity consolidation, including the expanded geographic footprint of hospital systems, we desperately need access to these data. You mentioned the critical reason for the federal government to act, and that is because of that 2016 Supreme Court decision that ruled that states cannot compel self-insured plans, which are regulated under ERISA, to supply their claims data. So we really need your help to enable an all-payer claims database. And finally, you asked whether current efforts on price transparency are enough. And my answer to that is simply no. The transparency that is out there now, and that's for two reasons. One is that what is transparent now, to the degree that it is transparent, as Senator Grassley mentioned, there are a lot of issues with how it's being reported, is just price. And in order to understand our nation's spending, we need quantity too. So we have the prices for every possible, or could theoretically have the prices for every possible combination of service, insurance plan, and provider, but we don't know how many of those triplets are actually being delivered. And without any access to information about the quantity, we're swimming in the dark. And a second reason is that that data has been extremely difficult for researchers to assemble because it is spread out in a range of places and not uniformly reported.
I appreciate that answer and look forward to working with you and others to try to address this issue. Dr. Fielder, a question for you about hepatitis C, but especially prescription models. And hepatitis C is a growing disease with a rate of reported acute cases increasing 400% between 2010 and 2020. There are approximately 2.5 to 3 million people living with the disease. It also has lots of side effects that lead to other complications, but it is now curable with oral direct-acting antivirals. However, even with the competition and generic drugs in the market, the cures can be incredibly expensive, $24,000 or more for a course of treatment. Louisiana, with the support of CMS during the previous administration, implemented an innovative subscription model wherein they negotiated a bulk price in order to get unlimited doses of medication for Medicaid and incarcerated patients, and they also set up a screening and prevention program. My question to you is, do you agree that that subscription model can work generally for diseases like this, and specifically, how can we at the federal level learn from that with respect to hepatitis C?
Thank you for the question. So I think it generally can make a lot of sense for a payer to offer a manufacturer a somewhat larger total payment in exchange for a much lower per dose price that facilitates broader access. And I think a subscription model, as we've seen in Louisiana, can be a very good way of achieving that. I also think that there's a particular logic to the sort of federally run subscription model that's currently being discussed in the hepatitis C context, given where some of the access barriers we've seen here have come from. There's something of a collection action problem among payers, where society as a whole would be better off if there was broad access to these drugs and we avoided the downstream complications and new infections that come from active infections. But since people bounce from payer to payer over time, no particular payer is really that motivated to be the one who makes the upfront investment in identifying cases and treating them. I think it's also relevant that Medicaid is an important payer here, and historically it's been a fairly stingy payer across a variety of domains, and we've seen that specifically in the domain of sort of the coverage policy states have adopted with respect to hepatitis C. So against that backdrop, I think having the federal government adopt a subscription model with respect to hepatitis C and then make the drugs available at very low cost to Medicaid or other potential payers has a strong rationale.
Thank you. I appreciate that. And we may draw upon your expertise. We're in the process of putting together legislation on that initiative. Thank you, Mr. Chairman.